Cheryl, part of the context to people living with HIV is that some people will be from vulnerable and marginalised groups, and health inequalities in the public health jargon is an important facet of all this, isn't it? So where does addressing health inequalities fit into people living with HIV and ensuring they age well?
Yeah, I think health inequalities have been around for quite a long time, but I think obviously quite recently there's been a lot of attention towards it. I think there definitely was a move last year for a top-down approach from the government around addressing health inequalities, and it would be nice if there were some sort of targets and funding behind that. But I think at the local level we can still look to that health inequality agenda. And again, that's going to be locally specific. So, I mean, people living with HIV probably across the board tend to come from, as you said, marginalised communities. And by that, probably we're talking about, obviously, gay men, people from Black African communities, but also sex workers and homeless people that you mentioned before. So we're talking about different sort of sets of health inequalities. I think, realistically, what we're looking at is a shift in expenditure, and I absolutely understand what Jim's saying about sort of resources being tight, and we know resources are tight across NHS and local authorities. But if we actually are serious about health inequalities, I think there needs to be some money behind the warm words, and I think there's all sorts of strategies that have worked or worked less well. We've got a lot of evidence about what does and doesn't work across the last, say, 20 years or so, but unless there's some money behind that fund, there's not going to, the ICSs aren't going to be able to sort of deliver those I was going to say far-reaching, but they shouldn't be far-reaching. This should be what we're thinking about. This, you know, there should be equality. Why is health inequality even acceptable? So actually, potentially, this should be the priority, you know, and we'll see what. I'm getting some nods, but I'm not sure. You know, it's easy to say that, but I'm not the one making the decisions over the money. But actually,
I completely agree with all of that, and I think that your point about limited resource. I think what you're also saying is that in times of limited resource, it's even more important that we invest our monies, you know, invest our resource into the places where we'll get a really good return on investment. So, and I think that's true for HIV or whatever you look at. I think if you look at Marmot's research, that's Michael Marmot's research, it shows that under the times of austerity, when we had a reduction in investment in the public sector, that led to a reduction in life expectancy. So, you know, there's clearly a link there between investment in public services and in health and care, and then what that goes on to cost the system in future years. And we know in terms of deprivation in our local area, people in our most deprived areas have over 3 times as many admissions to hospital, and their longer length of stays are 5 times as high. So there is a cost in not investing in health inequalities that is far greater than the cost of investing in health inequalities. And I think that's the point we need to really demonstrate here with HIV. And there has been some national funding around health inequalities, and locally in North Central London we have this 5 million inequalities fund, which we've put into low-level, preventative, community-empowered, co-produced schemes where we are demonstrating a difference. So an example being, we've invested in navigators for people with severe and multiple disadvantage, who cost us 10 times as much as your average resident. And already, I think they've produced something like 800 A&E attendances. So if you think what the impact has been in a wider economic sense in terms of getting them back into work, it's far greater than that. So I think there's a really strong investment argument for investing in health inequalities, but we have to understand what the need is and where that limited resource best goes. I think saying we just need to invest is not detailed enough, and I think as part of Core 20+5, we're really keen to make that plus part around inclusion health, which I think HIV could be part of. So, yeah, I think there's real opportunities here to make it part of a national programme around health inequality.
Could you explain the Core 20+5?
Yes, so Core 20+5 is a national programme addressing health inequalities, made up of looking at your Core 20, so your 20% most deprived, which is the population that has the worst health outcomes, then a plus population which ICSs can choose themselves. So in North Central London we've looked at inclusion health populations, and also some ethnicity groups which have the worst outcomes, and then 5, which is the clinical indicators. So it's meant to be it's a combination of things, combination of populations where they have the worst health inequalities. So some of this is directed, but there is that scope for local determination as well. So I think it would be good for HIV to think about how they could position themselves as being part of that plus populations, because there is some funding attached to it.